eye using cotton buds or poking inside the ears, and therefore the only two plausible explanations are that some sort of foreign body flew into the ear, nipped the side of the ear canal, and maybe even an insect bite, but and that insect then escaped out of the ear. So they went to see their GP because they had this bit of weeping blood from the right ear, and they were advised to visit myself so I can clean that out and see what's going on behind that crusted blood, because in case of a perforation to the eardrum, for example. So just removing this occluding wax from the left ear first, it came out relatively easily. It was quite a substantial piece, and I managed to manipulate it out of the ear, which is a bit bendy, as you can see here. The second bend, the ear canal veers off to the left. That's the eardrum, it's really, really healthy. And now we're going to tackle the right ear. So the plan of action is to remove all the dried blood first, and then we'll approach the eardrum slowly but surely. We just have to be on the lookout for any abnormalities in the ear canal, for example, necrotizing otitis externa, which is a very rare condition, but it's when the underlying bone of the ear canal is infected. It can be quite serious. It's a rare condition, as I mentioned, and people who suffer from diabetes or immunocompromised or elderly are more likely to get it. Despite it being a rare condition, it doesn't mean that a normal individual can't get it. And the underlying condition is called osteomyelitis. It's when the bone gets infected, and that infected bone can then spread up to the skull base. It can lead to a brain abscess, meningitis. It can be fatal. It can also go up towards the facial nerve, which sits in the middle of the ear next to the stapes foot plate, which is where the smallest bone in the body, the stapes, also known as the stirrup, connects the organ and the cochlea. It can go towards the temporomandibular jaw joints, to the front part of the ear canal, and also posteriorly to the mastoid cavity, so the bone behind the ear. Typically, however, with necrotizing otitis externa, you get a massive granulation tissue, which is inflammatory tissue, which fills up where the bony part of the ear canal meets the cartilage portion of the ear canal, so about a third of the way and around a centimetre from the top. So you get a big massive granulation tissue from the floor of the ear canal. Normally not a discharge, so I don't think it's that. Underneath here, potentially, you never know, it could be a canal cholesteatoma. So that's when you get ulceration of the skin and the underlying bone starts to die. Okay, so it undergoes a process called necrosis, and you get sequestrial bones, so loose bone fragments. Again, that can be potentially very, very dangerous, similar to the necrotizing otitis externa. I don't think it's that, but we don't know. It could also be a condition called benign osteitis, which is sometimes difficult to separate from a canal cholesteatoma, but a benign osteitis is when the bone gets infected underneath the skin. So it's less severe than necrotizing, it's not spreading, it's more localized. But the skin generally can still be intact, or the skin can later become ulcerated. So a benign osteitis and canal cholesteatoma, you generally get craters within the ear canal. They're normally in the inferior posterior quadrant of the ear canal, so what I mean by that is at the back part of the ear canal near the floor. But yeah, benign osteitis and canal cholesteatoma can be difficult to differentiate at times. But I think with a canal cholesteatoma, you just know it's a bit more aggressive, it's a lot more discharge there. Benign osteitis, sometimes you don't even get discharge. Still not sure. All I can see here now is the skin is inflamed, it's swollen. Just going to see what's underneath this blood. That's quite important to remove. And the patient was elderly, so they're non-diabetic though. They don't take any blood thinners. They've got no compromised conditions that they're aware of. And these things are important. Because if you're diabetic, you've got less blood flow going to the peripheral parts of the body, so including the ears. So disease, the immune system is compromised because when you've got a reduction of blood flow, it's less able to fight infection, provide the body with all the blood cells and nutrients that it needs to help fight infection. So you've got to be careful whenever you've got a diabetic patient, someone's immunocompromised, the immune system is weakened and less likely to fight infection. When you've got someone who's elderly, they can also become immunocompromised just through age. So these three factors are quite important. You can review X, and you spot a pathology, can help with your diagnosis sometimes. It's really crusted, and I put a lot of drops in. You've got crusted blood in the ear, in particular, especially on the bony part. This is on the cartilage part, which there was a bit earlier on that removed. It's far easier to remove, but you've got applying pressure against the canal wall, which is very tender and inflamed, as you can see. And the bony part of the ear canal, it can be very unforgiving. I don't know if you can see at 9 o'clock, you can actually see the long process of the incus. That's the middle bone, also known as the anvil. You can see it like an inverted L, or should I say a mirror image L. So it's flipped horizontally. So that's the hammer bone is the bone in between the suction probe and the crusted wax on the anterior canal wall. The front parts are right in the centre of the suction probe and the crusted blood. You see that's the hammer bone. The incus bone is actually obscured at the moment by the suction probe. But you don't always see the incus bone, especially in elderly patients, because the eardrum becomes a bit more opaque and a bit more tympanoscopic. You get a build-up of calcium deposits in the eardrum, making it a bit more opaque. So you can describe it as scar tissue if you like. But in this patient we can see it just about. We know the eardrum's in good condition, but again, there might be a perforation here that we can't see. It was slightly uncomfortable at times for the patient, unfortunately. And when I removed this and held it in between my forefinger and thumb with the gloves on, despite all these drops that I put in trying to soften this, it was really razor sharp, and it did nick the ear. Because I removed it with forceps because it was so rough. Eventually I do remove it with forceps, but at the moment I can't use forceps. I can't use any other instrument apart from suction because naturally, I don't know how to explain it now, but I can't use a hook or just a horn when in this position on the waxes. Forceps is nothing to grip onto at the moment, so I'm just having to persevere with suction. But eventually I manipulate this. And there's a lot of this crusted blood in behind that canal wall at the front that's swollen, and that region that we're working at the moment is called the anterior recess. So you'd be quite surprised by how much of this clotted dry blood is actually hidden away in that anterior recess. When you've got really dry crusted blood or even wax, it's much harder to get a suction grip. The tip of the sucker almost glides across the surface and it doesn't grip because it's so rough and dry. Hence why I've got loads of drops, and I'm actually there and again, the drops are still in situ. I haven't performed the procedure whilst the drops is in there. I've allowed it 5 minutes to rest, if not longer as well. So I've just bent the tip of the suction probe because we don't want to make contact with the front part of the ear canal, because as you can see it's going to be bruised. So I'm quite confident there's no those pathologies that I mentioned earlier. There's no benign osteitis, canal teratoma. This is not processes of trends. There's no necrotizing metallic explained. So I'm not entirely sure what's caused the bleeding now. So probably the bets are at the moment with the underlying perforation. Explain this, but there wasn't. So as I said, I suspect if the patient hasn't been poking me, and they were quite adamant and they haven't, either a foreign particle or floated to the ear, nicked the side of the ear canal. Sometimes patients can unknowingly scratch inside the ear, especially at night. It happens a lot actually, and they're completely oblivious to it. I had a couple of ones where the patient's partner got a video that they took at night with their partner scratching the ear, and the patient just wasn't aware. So they're doing it in their sleep. But I doubt it was that. Like, I just don't think that was the case in this particular patient, because this is so deep in the ear. It's about between 2.5 to 3 centimetres in the ear. They've got a narrow bend ear. They just wouldn't be able to get their finger in that deep. So I got a bit I'm going to say excited, or I'm trying to think of one for a better word there, but I brought it forward, but it just still wasn't powerful enough to remove. You can see I've somewhat lifted it off the front part of the ear canal. And the worry is, and it did happen, that I pushed it further back in, I positioned it back into that anterior recess, which is what we don't want. I'm trying to lift it up, but because of that swelling anteriorly, it's blocking the path for this crusted blood to come away. See, I'm trying to hold it from right to left and screen. So I'm trying to curl it around the front part of the ear canal, but it's actually a lot harder than I initially thought. It still gets squeezing it through. And you can see the edges, so there's a bit about 8 o'clock. Just resting against the left-hand side of the floor of the ear canal. And I think that was the part that, when I removed this, because it was so sharp, and it nicked the side of that part of the ear canal. So there was a bit of bleeding that occurred after this procedure, unfortunately. The roof of the ear canal, that crusted blood is also gets captured at the roof. You can see there when focused on the it goes. So that's trapped it. Just put loads of more drops in, and it has softened that top part. It's come down a bit. I had a bit there to grab on to pull this forwards. I had to release because the patient found it a bit uncomfortable, but fortunately I managed to bring it through, and it's just between the first and second bend now, so I'm going to go back to the suction probe and vacuum this out. Just a little bit left there, but you can see there's some fresh blood developing, and I suspect it's because it just nicked the back part of the ear canal, and there's a bit of blister forming there. So I'm just going to suction it. I'm going to try and stem that bleeding. It's a bit deep to put anything inside to kind of compress that. By the end, I'm going to start to do a pressure test just to check, make sure there's no perforation, which there wasn't, which is great. I was just worried about that pool of blood collecting and falling into another crusted piece of dry blood. So I have got the patient coming back, I think, next week, just as a precaution, just to make sure there's no fresh crusted blood, but by the time we left, this has stopped bleeding more or less. And that's the inferior recess. We can get some collection there quite easily. You can see there's no perforation here, it's very healthy. In fact, I think by removing that crusted blood, the eardrums come forward, it's flexed naturally a bit towards me. Just gently, I don't make contact at all with any of the flesh or skin or marble of the eardrum at all. I just want to hover over. I'm just trying to help the blood coagulate. Blood before it kind of oozes down to the inferior recess. The inferior recess can be very difficult to remove objects out of. So this is about a couple of minutes afterwards. And so there's some blood just trickling down towards me. It's a little bit left also. A little bit has also again collected in the inferior recess. And it's going to wash that up. told by their doctor that they've got some dry crusted blood. Naturally, I think any of us would be a bit concerned as to the cause of that. But it doesn't look like anything sinister here. And this is, again, about 3 or 4 weeks later, whilst I was booking the patient in for their follow-up, just a quick check-up. So in that time, just a little bit collected, but you can see it's really stemmed now, so which is good. This was just before the end of the appointment. I did one quick look again. So yeah, a bit more collected in here for a recess on that account. So I did advise the patients if they do get any trickling of blood at night, not to be concerned, but obviously if it's bleeding a lot, call us back.